Welcome everybody to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for July 6, 2023. Today's CME activity code is 488885. If you have any issues getting CME credit, let us know. We're glad to help you out. This conference is being recorded. As usual, we have really nothing to disclose related to the conference, and we try to maintain patient privacy by removing all identifying information and changing dates, etc., to disguise the identity of the patient and protect their confidentiality. I have the case today. It's a fun case. It's a little interesting. We say that every week, but hopefully it's true. And as usual, even when it's not, our great faculty and guests always seem to make something fun out of it. So I think this will be a fun case. Patient is a 75-year-old Hispanic woman who was referred for rising creatinine. She has a history of hypertension for 5 years, diabetes for 3 years, a seizure disorder, hyperlipidemia, hypothyroidism, osteoporosis, and lupus for 45 years, but really manifesting only as occasional arthralgias. And she's been controlled with Plaquenil alone. She's never been on prednisone or Imuran, etc., MMF. Her creatinine was 0.8 for the past 9 years, the records I have. In six months ago, she was hospitalized for abdominal pain and anorexia. And at that point, you can see on the graph here, she had AKI. She was found to have pneumonia and a lung abscess and received several weeks of Augmentin, but has been off it for at least 3 months. Her creatinine peaked at that hospitalization, 4.9, but it decreased back down to 1.8 on discharge. Since then, her creatinine started rising again and progressively increased, even though she felt fine and was taking no new medications, and she was completely off antibiotics. She was referred to us, you can see here on the graph, when her creatinine was 3.1. We repeated it 3 weeks later, and it was 3.6, and made a decision to go ahead and do a renal biopsy. She denied any non-steroidals or over-the-counters or herbal medications. She denied edema or rash or any systemic symptoms, and her joint pains were stable. Past medical history is significant for diabetes, hypertension, hyperlipidemia, and hypothyroidism, and her seizure disorder. She carries a diagnosis of protein C deficiency, but is unaware where this came from. She can't remember ever having a clot anywhere, nor is she on anticoagulation. No past surgery. Her father had end-stage renal disease from diabetes, long past. She had a 40-pack year smoking history, but quit about a decade ago, I think. She's allergic to peaches and seafood. Feel bad for her. I love peaches and seafood. Her meds are Synthroid, vitamin D, losartan, Keppra, Plaquenil, and rosuvastatin, which is Crestor. On physical exam, her blood pressure is 130/60, heart rate 70, respiration rate 60, temperature is 97. She was 5 feet and weighed 120 pounds. Her physical exam was really normal. I couldn't find anything. She hadn't rash or edema. She looked quite healthy. Looked great. On laboratory exam, her sodium was 144, potassium was 4, chloride was 107, bicarb was 20. BUN was 60 and her creatinine was 3.6. Her blood glucose was 80, her serum albumin was 3.9, her total protein was 7, her calcium was 10. The bilirubin, ALK Phos, ALT, and AST were all normal. Her cholesterol was 175, her hemoglobin A1C was 5.1%. Her CBC had a white count of 3.3, a normal differential, however. Hemoglobin was a little low at 8.5 with a high MCV. This has been around a while, and I don't think I put it in here, but folate and B12 had been checked in the past and both were normal. Platelets were 190,000. Oh, there they are. I'm sorry. Folic acid was 20 and normal. B12 was normal at 680. Her urinalysis had a specific gravity of 1016, a pH of 7. Dipstick was 2+ protein, was positive, but no blood. She had no white cells, no red cells. She had 12 Highland casts. Her urine protein ratio was 1.1 gram per gram, but her albumin creatinine ratio was only 160 milligrams per gram, or 0.16 gram per gram. Serologically, hepatitis B surface antigen was negative. Hepatitis C antibody was negative. ANCA was negative, but being both MPO and PR3. Double-stranded DNA was slightly elevated at 15, but her complements were normal as C3 of 90, a C4 of 20, and her SED rate was elevated at 36. She had a serum and urine immunofixation, both were without paraprotein. Again, I ordered serum-free light chains, but somehow I'm ordering the wrong test because they weren't available. I looked back and found a protein C activity from several years ago, and it was normal, so I'm not sure what that means. her history means. A renal ultrasound was unremarkable, and a percutaneous renal biopsy was performed. So I want to start with a poll.
Oops, give me a second here. I'm sorry. There we go. Hold on, the poll will be up shortly here. 1 second. You can start reading the question though.
So poll number 1, what will the biopsy show? Mesangial lupus alone, class 2, membranous lupus alone, class 4, a proliferative lupus nephritis, 3 or 4. Certainly seen that without active urine. 4 would be actually, I should just put interstitial nephritis, but I put acute allergic interstitial nephritis. So we'll just put it, number 4 is interstitial nephritis. And 5 is a TMA. So is the poll active?
Second, people should be able to see it. Give me 1 second here.
Roger,
Yes, Mario.
I have 2 questions and a comment. What did the peripheral smear show?
Peripheral smear was unremarkable. She did not have any eosinophilia.
Okay. Did you do a urine protein electrophoresis or just a urine immunofixation? The reason I'm asking for the audience is because I see that there is a hint of globulins in the urine, which may support the diagnosis of tubular interstitial disease. Because you ruled out overflow by your immunofixation.
It was only a urine immunofixation.
All right. And number 3, you meant class 5 membranous, right?
Whatever I said was wrong, obviously. Thank you. Yes. Yeah, that's not a good start for a renal biopsy conference from an institution who prides itself on lupus nephritis.
You were never good at math.
I was never good at math. But thank you very much, and thank you, Pravir, for not repeating that error in the poll. There you go. That's my man. That's really funny. Thank you. So here we've got, is it still running? Yeah, people answer.
And put your answers in. You should be able to see. We have, wait for a little more here.
Yeah, wait a little bit more.
More. There we go. 60%. There we go. There's some coming in. I think that's pretty good. All right, I'm going to end it here. You should be able to see it.
So here we've got kind of a spattering of diagnosis. We've got mesangial lupus, proliferative lupus, interstitial nephritis is the winner at 40%. Proliferative lupus, despite a normal urinalysis, is a quarter of them. Nobody bought into my class 4, class 5 membranous lupus, or one person did. A little bit of mesangial lupus alone, which I think is interesting, and a TMA was thrown in there because of her benign urine and her history of the protein C deficiency. So let me hand it over to Dr. Whittier from the sunny state of California. Bill, you outside, or is that a fake?
No, I am outside. So if you hear like a helicopter going overhead, it's real.
Chasing OJ.
So yes, I'm in Brentwood. So yeah, I think this is an interesting case because I really wasn't thinking about a glomerular disease here. Obviously, if you biopsy patients with lupus and they have less than 1 gram of proteinuria and they're not really that active serologically and they have normal renal function, they're 50% of the time they'll actually have a proliferative lesion. So we can't always use the clinical presentation to predict the histologic lesion in lupus and in lupus nephritis. But when I see this much discordance of significant renal failure, not much active in the urine, a likely tubular interstitial pattern of the urine, or maybe even a vascular pattern of the urine, I think about interstitial nephritis or a thrombotic microangiopathy. So I probably would have leaned towards 4 and 5 of the poll in someone with a history of lupus. Those could both be in the setting of lupus, but also people or lupus patients are often on medications, such as NSAIDs or other medications that might cause interstitial nephritis as well. The fact that she has a strange history of protein C deficiency, but then that was negative, and it's a little confusing, but that might actually increase the likelihood of a TMA. Another thing I was thinking that's actually not on the top 5 that you put up there, but I would mention is that she does have a low AC/PC ratio in the urine, and she also has a mildly elevated calcium compared to her significant renal failure. We'd expect her calcium to be a little bit lower when her GFR is so reduced. And so when I see a calcium of 10, I'm not saying that's quite hypercalcemia, but when we have a calcium of 10 with this high of a creatinine, we do want to think about other causes of tubular interstitial diseases, such as granulomatous diseases. Sarcoid might fit in well with something like that. Or obviously, we would think about myeloma. And if you had that discordant urine findings and the immunofixation in the urine was positive for a protein, then you'd think about Benz-Jones proteinuria. So you have the negative immunofixation there. But those were all the things that I was thinking as I was going through the case.
So in the chat, Dr. Rajasekaran brought up ALK2 amyloid. What do you think about that?
Yeah, I don't remember what her ethnicity is. We think about that almost exclusively of patients of Mexican descent, but
she is Hispanic.
Hispanic, okay. Yeah, and that certainly is a tubular interstitial type of amyloid and would fit the pattern. I don't typically expect acute kidney injury with that, although it is possible.
Yeah, and that's what Dr. Reen said as well. You wouldn't expect it, but somehow you got to put it all together. I mean, I suppose the same thing could be said about IgG4 disease. It's kind of an odd, we do odd cases here. And me not putting ALK2 in the poll, it could mean one of two things. I mean, it could mean that it's not a possibility here. It could be that I'm messing with you, because I certainly do mess with people, with the audience in the polls, if I don't think something is, super likely. But Dr. Gashty, what are your thoughts? What do you think this patient has? You made a comment in the chat that it has to be something to do with lupus, because I put 3 lupus diagnoses in there.
Yeah, I agree with Bill. I think that her serologies are so quiescent, and at her age, if she hasn't had any issues with lupus, it would kind of be unusual for somebody without hematuria, without any serologic activity, to all of a sudden have AKI from lupus. And the pattern that the labs kind of read tubular interstitial based on her low-level proteinuria and mostly non-albumin proteinuria. So those facts lead me towards the idea that the reason her creatinine is going up is because of some kind of a tubular interstitial involvement. So to me, I think choice 4, either acute or chronic interstitial nephritis, seems reasonable. And some of these lupus patients, when you biopsy them, they have some mesangial deposits. So I wouldn't be surprised if she has a mesangial lupus, but I'm not convinced that would make her creatinine go up. And neither would, a membranous, unless there's either like a crescentic membranous or something that's a little more aggressive or proliferative in nature. So, and I don't think 3 proliferative, it just doesn't seem, with negative blood and the negative serologies, I just have a hard time accepting that this lady has a proliferative nephritis with nothing else to find. So I'm going to go with a tubular interstitial process, maybe a chronic interstitial nephritis, maybe with a background of mesangial lupus.
So we've certainly seen plenty of bad glomerular lupus patients who don't really have a clinical, the urine that clinically supports that. And the serology is pretty unimpressive as well. But yeah, I mean, it's pretty glaring. It's hard to believe. But how do you feel about, since your number one, both you and Bill, number one diagnosis is something interstitial, there's really no white cells. There's no white cells.
I'm okay with that. I've seen pretty bad interstitial nephritis with not much pyuria.
Well, I guess what can I say? Your nickname is Dr. Interstitial Nephritis. For whatever reason.
But the UA seems to be pretty non-specific when it comes to diagnosis of interstitial nephritis. If there is pyuria, that hints towards it, but the absence of it, I don't think makes it, that much unlikely. Because I mean, you can also say the same thing about, whether there's any of the GNs that are on the list would have with no hematuria and proteinuria. It would be less likely for him to have a glomerular disease if there's really no blood. So,
and that's fair. I just think someone whose creatinine is rising this rapidly, yeah. I would have expected some pyuria, but I don't really know.
When we're talking about interstitial nephritis too, we always should examine the medications. And you said that she was off the Augmentin at the time, so that would be the obvious one. But she wasn't on that. And then we think about NSAIDs, of course. But the other thing to think about, not necessarily for causing AKI interstitial nephritis, but that her Crestor could cause this level of proteinuria because it's well known to cause tubular interstitial proteinuria as well. So it shouldn't cause a kidney injury, maybe in the absence of rhabdomyolysis or something, but that could explain her baseline urine findings, and she really doesn't have anything significant in the urine consistent with her AKI. Maybe it's just all ATN from something.
So,
And if you look at the graph that you were showing, it looks like her creatinine was before her pneumonia AKI. The creatinine graph looks like it's uptrending for a long time. So I'm not really sure if this is really AKI or, I mean, the end of the graph looks like AKI, but it looks like she's progressing for some reason. And then the pneumonia makes it spike up and then go back down to some level of CKD. And then she gets another episode of AKI / progressive CKD. But if you take the pneumonia spike out, it looks like your typical CKD progressing.
yeah, I think that's a good point. Except that it's really accelerated, and if you're going to call it that, I think you're still kind of having to call it AKI and CKD. And the AKI is still, I mean, I saw her and I was like, what's going on here? I don't know. And let's just repeat it, you know, and you don't know what to do, you repeat things.
Sure.
And I repeated it, it was going up, and I said, well, you know, I can't take a chance here. I know the urine's, you know, like you said, not reliable, but something's going on here, and I need
the weight loss thing is also interesting, right? She's losing weight. You said she's fatigued, losing weight. I'm not sure how to tie that into the whole thing.
I mean, I'm sure, you know,
She's not losing weight.
Your analyses can always be, I guess, off, as you were saying, Casey, but she's got 12 hyaline casts. I mean, this urine has to be, you know, it's got fairly concentrated. They can see 12 hyaline casts, and you don't see one white cell. I just find that interesting for someone with an acute interstitial nephritis.
Yeah, Dr. Reen is. A few people have jumped on this on the granulomatous diagnosis, sarcoid. You know, it's certainly a thought. I wasn't impressed by the calcium with that albumin. I didn't think much of it, but and you don't have to have hypercalcemia with sarcoid. You don't have to certainly don't have to have systemic symptoms with sarcoid. I mean, as nephrologists, the patients that we see, the ones I see are the ones that don't have obvious extra renal sarcoid. Otherwise, they wouldn't come to the nephrologist for the diagnosis. So that's always a fun diagnosis to make as a nephrologist. I want to say 2 words about Crestor or Rosuvastatin, because we were kind of in the at ground zero for that when it was getting approved. Because Dr. Lewis was on the FDA committee to get it approved, and they brought him in because it causes proteinuria. And it was quite a battle because you know, anything with the FDA, that kind of side effect, the renal disease is a very bad side effect. And it took them a while to convince that actually what was going on was that it was not a tubular damage function, it was a tubular function problem. And that cholesterol is important somehow for megalin and cubilin to work. And by lowering that and lowering and again, I'm not going to do a good job of this, but it had to do with that process of megalin and cubilin and the proximal tubular cells being able to reabsorb proteinuria. So it created tubular proteinuria with reversible tubular damage. And there was no evidence that it caused any permanent damage. So I'm glad you brought that up, Bill, because that would be exactly the pattern. I don't know if they got as high as a gram. This is about a gram of tubular proteinuria. I don't think they quite got that high, but certainly for the FDA, 300 or 400 milligrams is a big deal. So,
Roger?
Yes, Dick.
I think some attention should be paid to her hematological manifestations because she has a rather severe macrocytic anemia in the absence of folate or B12 deficiency, which suggests reticulocytosis and possibly hemolysis. And it's well known that infection can induce an anti-phospholipid antibody. Whether or not that increases in patients with a previous diagnosis of lupus, I don't know. But I'm wondering whether this infection that she had provoked an exacerbation of a antiphospholipid antibody syndrome, and that these hematological manifestations are reticulocytosis.
Yeah, that's a good point. I went
Did
back.
you do an LDH?
I did not do an LDH, and it's one of my favorite tests. It's not on. It's a shame because it's of no value sensitivity. It's not specific for anything, but it has nice sensitivity. So no, I miss the LDH as part of CMP, but I did
what
not.
did
But I
you
went
think
back
was
and
the-
Dick, I went back and I looked, and this has been going on quite a while. It certainly preceded her infection, and that's what prompted the folic acid and the B12 in the past for the macrocytic anemia. And in fact, if you look at her, white count's a little low, and she's fairly anemic. And I didn't know how much the anemia was related to just her being sick and having acute renal failure or not. It seemed out of proportion to me. So she may actually be more on the pancytopenic side, and she may have maybe a myelodysplastic or something like syndrome underlying all this. And I'm sorry I interrupted you, Dick.
No, I just wondered if you ever tried to evaluate what the cause for macrocytic anemia was.
Not beyond, I did not, and beyond the fact that because it had been going on quite a while, and they'd initially looked into it with the folate B12, which is hardly everything.
Okay.
And I don't know if she would have to have a chronic hemolytic anemia, we're talking about a couple of years, because it's been going on a while. But that's always possible. So no, I do not have that information. So Steve, what do you think?
I think everybody's covered it pretty well. I kind of fall back on a chronic tubular interstitial process, whatever the cause may be. I think all the other things have been discussed already without going out too far on a limb. But that's, just from looking at this, and that was the first thing, especially with this urinalysis. I mean, that something that bland with that kind of proteinuria, and again, it's been brought up several times now. It looks like this is not albuminuria as much as it is something else, and it's not light chain. So I assume it's beta 2 microglobulin, unless this person has myelomonocytic leukemia, and then it would be something else. But I think there's going to be a chronic tubular interstitial process.
What Steve was referring to is lysozymuria, which is probably infinite. You see it 1,000 times.
Talk about it all the time, never hardly ever see it.
There was recent case report in AJKD, but it's pretty rare. But they produce lysozyme, and it's the other overflow proteinuria besides, and it causes acute renal failure too, which is the part I didn't know until I recently saw that report. Let's take a look at the pathology. Let's see. Ask the whale.
Give me a second. Give me a second. Don't worry, Nirali, you're not on it.
Yeah, we're glad to see Nirali, past fellows on today. And two of our just graduated fellows are on.
There we go.
Okay, there we go. Dr. Gashti. How
Now
appropriate.
you know it's going to be interstitial.
Yeah, that's right. Okay, we'll see everybody next week.
All right, give me a second here. Right, and then I will give you control. Go ahead and click on the screen. Yep. In the bottom left. Yep, there you go.
All right.
This is payback for me losing rock, paper, scissors on the last time.
Can you hear me okay, Roger?
Yes, David.
All right, so here's a trichrome stain. There's a big slice through a big artery right here in the middle, but
Yeah, so that'd be an arcuate artery with the cortex to the left, medulla to the right.
yeah. Although there's one glom hanging here to the right.
Yeah.
You can kind of see the separation here. I do see some blue staining material, some separation of the tubules. So there is some chronic fibrosis. I would say on the top, it's a little hard. Maybe I would say, I don't know, somewhere around 50% or 25 to 50% on top, and then maybe 25% on the bottom. I don't know, David. I do see some cells. I see some dots on the bottom core, but I'll wait for higher power. So at this point, I think we're just going to comment on the just chronic damage here. What do you think? 25 to 50?
Yeah, I agreed with you, Casey. Yeah.
Okay.
Not many glomeruli in that bottom sample, right, David? I mean, I don't see.
Right. Yeah. There's
I don't
only
see any.
we only got 2 on the light microscopy.
Okay. We see one of them is hanging off the edge. So here's a PAS stain. This glomerulus looks pretty good. I don't see any hypercellularity. I don't see much in terms of maybe mild mesangial expansion, but that's really kind of focal because some areas, like for example, here and here, there's not much mesangial expansion, but there are some areas. And then I do see separation of the tubules, some wrinkling of the basement membrane, some thickening of the basement membrane. So those are all signs of just chronic tubular injury. So the idea
Good,
of
good, yeah.
maybe
And a little fibrosis between them as well,
Yeah.
the collagen, yeah.
and there's
then
also periglomerular fibrosis here.
yeah. Also at 12 o'clock, there's an arterial that looks normal,
Okay.
right above the glomerulus. Yeah.
This,
Yep. Yeah, that's an arterial.
that's not a distal tubule, huh?
No, because the cells lining it are smooth muscle cells.
I see. Okay. All right, jumping straight to a Jones stain. This is the same, I assume, glomerulus. This is hanging off the edge, maybe not, but these capillary loops are very thickened and they do also look irregular. I see definitely maybe the loop down here. There's much thickening. I don't necessarily see spikes unless I'm missing them. I don't see.
Yeah, there might be a
holes.
little wrinkling in that area there.
Yeah.
Or
Trying to see. I see some hint of spikes up here. I guess we'll see an EM, but this basement membrane seems so thickened that I can't really see any holes or spikes or anything.
David, any chance it's just a little overexposed or?
yeah, I think it's a little overexposed, a little.
Do you see any
overstained.
holes or spikes, David?
No.
Okay. All right. So overexposed, but not thickened. You
Yeah,
think these
maybe
are normal?
maybe mildly thickened in a
Mildly
couple of
thickened.
them.
Okay.
Yeah.
So maybe there's a possibility of membranous. Yeah, this is definitely the same glom. It has the
For
same
diabetes, right? The guy's diabetic.
periglomerular fibrosis.
Yeah.
I guess there is some hint of mesangial expansion here, but not fully a KW nodule, because we saw this glomerulus at the last on the PAS.
Yep.
It was PAS. It was pretty staining pretty pink for PAS, right?
Yeah.
Okay.
Yeah, there's no amyloid. Congo red was negative.
All right, so here's H&E core. This is, I don't see any glom, so this must be the medullary region. Wow, there's a lot going on here. So there's thyroidization of these tubules here. There is cellular infiltrate, but since this is an area where it seems like a lot of chronic damage, this is probably just chronic interstitial nephritis. There are really not that many. This is one maybe semi-healthy tubule, and there's maybe 2 or 3 on this side, but this is, 80%, 90% damaged tubular interstitial space. Yeah. And there's a lot of fibrosis in the interstitium itself.
David, is there any specificity to the thyroidization for the people that aren't used to that term? It's the dilated tubules with proteinaceous material in them, and it looks like thyroid. So is
Yeah,
there any
typically it's
significance or
seen
just
in.
chronic? I'm sorry, David.
Typically, hypertensive nephrosclerosis is the most common condition.
Casey, if you take a look at those, they look fractured to you?
I see what you're saying here. I see what you're saying here, but these are pretty much already dead tubules. So if they were in the middle of these maybe healthier tubules, I would pay more attention to it. But you're right. I mean, they are fractured. I mean, these look like they're lines of artifactual fractures here and here as well. But I see the same kind of lines here through the actual cytoplasm of the cell, but I don't see it. I don't see that they're casts inside of the functioning tubules.
Mario, you were
You're
saying?
hinting to a cast nephropathy. I don't see it here.
No, I agree. I don't see a giant cell reaction, which is the other part of cast nephropathy.
Good point.
Okay.
But you do see there's a fair amount of inflammation around those casts. I mean,
These?
yeah, right in there.
Yeah, but we see chronic interstitial nephritis in the dead areas of the kidney, right?
It's true. It's just that it being associated with those. I mean, maybe they're just hyaline casts like they saw in the urinalysis.
Yeah. So here's another H&E of the tubular interstitial area. Again, you see those thyroidization. I do see what Roger was talking about, these casts, but again, same comment as the last one. There's some also acute tubular injury. I see some destruction in the epithelial cells, the sloughing of the rush border. So
Yeah,
some
I think, yeah,
some
yeah,
ATN,
yeah.
but mostly chronic.
Yeah, and the ATN might even just be fixation. Because if you look
Artifact.
down at the tubule at the bottom right, when they don't get it in formalin right
Here?
away, it starts to autolyze. Yeah,
Okay.
I think that's more autolysis.
Okay. So basically the same as the last slide, just mostly chronic. And here you don't see as many cells. There's not much of a cellular infiltrate.
Yep.
All right, so here we have, we're sort of focusing on an area where there are more cells. They look like lymphocytes. These are red blood cells. I'm looking to see if there are any eosinophils. I can't tell if this is just like a red cell. Yeah, I think
that's
this
just
is
a
a
red
red cell.
cell.
I don't see any
Yeah.
eosinophil.
Looks like there are a few plasma cells as well.
Plasma cells would be up here. These.
No, down
Oh,
below.
yeah. If you go to the very top and to the right, there's like solitary plasma cell. Yeah, and straight up.
This right
Straight up
here.
from where you are. Oh,
Yes. The clock face.
yeah.
Okay.
Yeah.
All right. So intact tubules here with some, these are red cells in the capillary, peritubular capillaries. So that's not unusual. They're just unlysed. Okay. So some cellular infiltrate.
Yeah. No,
Somehow
like you
didn't
said,
make it into
no
the urine.
eosinophils, no granulomas.
No, okay.
Yeah.
So here's a glomerulus. This is an IgG fluorescent. There is IgG staining along the capillary, the Bowman's capsule, but there is not much going on within the mesangial area or the capillary basement membrane. You can see these in lupus, right?
Right. Yep. Extraglomerular staining.
Yeah.
Yeah.
I don't know what this is because it's just, I don't know if this is a tubule or an artery, but there's definitely some strong staining here, but there's definitely granular staining of the Bowman's capsule.
Yep.
Okay. Tubular basement membrane, all stained granular IgG pattern. So extraglomerular staining of IgG in the setting of lupus.
Yep.
It's more of the same.
Yeah. And immune type deposits.
Yeah.
So David, how do you go back, please? How do you differentiate this from this entity called Abba, my favorite rock group of all times? The anti-brush border antibody disease, now that we're talking about an autoimmune tubular process.
Yeah, I think we could talk about that at the end of the case.
Okay.
But did the brush border light up? I didn't.
No.
These are
And
basement membranes.
Yeah.
Yeah, I don't see brush borders lighting up here.
Yeah, these are tubular. I mean,
You almost see an ANA here, right?
yes. Yep. Yeah, there's Bowman's capsule staining, tubular basement membranes, focal vessels, as typically you would see in lupus nephritis. And actually, go back, Casey, to the glomerulus. There was, down at 5 o'clock, there was a little bit of mesangial staining. Yeah, right there.
This? Okay.
A little bit, and paramesangial in some areas as well.
Yeah.
So.
Okay. All right, here's an EM. This is the blood space. This is the urinary space. This is the mesangial area. Just kind of following the basement membrane. There may be a little bit of mesangial interposition here.
Yeah.
The basement membrane does not look thickened. In fact, it looks quite thin over here. The foot process, the podocyte that's on top of it, looks focally effaced. Here it looks fine. Here it looks, I actually can't really see it. So I don't know if it was lifted off, but maybe I'll take a look at a higher power.
Yeah.
But nothing that's sort of diagnostic. There are no
Yeah.
Deposits. There are no.
Oh,
no
yeah, and then
deposits.
in the mesangial area at around, yeah,
Here?
right there, there are some little mesangial deposits, yeah, right
Okay.
there, yeah.
Okay. Here's a higher power. See some red blood cells and some polys floating into the capillary lumen. Basement membrane looks pretty good. No subepithelial, no what is this here? Is that an old deposit?
Yeah, I think that's a small subendothelial deposit getting
Okay.
resorbed, yeah.
Okay. All right, so there's some hints of lupus here.
Yeah,
Nothing subepithelial
Yeah.
at the moment. And the brush border, I'm sorry, not the brush border, the podocytes, it looks good. It looks,
Yeah.
doesn't look effaced.
and then right at 9 o'clock,
Yeah,
Casey,
sorry.
before you went to there
Yeah.
was a small little mesangial deposit, right, and go straight down to the left a little bit.
Here?
Yeah, right there, yeah,
Okay.
yeah.
All right.
Now, this is the tubular basement membrane.
Oh, I see. So
Yeah.
you're showing these deposits, these
Yeah.
tubular basement membrane deposits you see all along here.
Yep.
And here as well. They're very small.
Yep.
And they're sort of, I don't know if it's the same for tubular basement membrane, but these look kind of like intramembranous. Is that the same thing? Does it start on
Yeah.
one side and
Yeah.
then just get absorbed and new basement membrane covers it? So this is a sign of just chronic old deposits?
Yep, yeah.
Okay.
Yeah, they're in scarred tubules like we saw on the H&E.
Okay, so the diagnosis would be, so we saw some mesangial deposits, so it would be class 2 lupus with some chronic interstitial nephritis.
Yeah, I agree exactly.
Can you explain the AKI? Or do you want
Not-
to stand
no.
by your original, this is not AKI, this is CKD?
It looked pretty beat up. I mean, it looked like a lot of just chronic fibrosis, but I mean, sometimes there's, tipping point, right? The creatinine stays at a certain level and then it just reaches that critical threshold and then the creatinine jumps because there's, 50, 70% fibrosis. I don't know. I didn't see anything that, to me, directly that says, this lady's creatinine went from 2 to 4 in a few weeks. That I don't see.
So I think we have another poll based on the pathology. So based on the pathology, what is your next move? Would you treat this patient with steroids alone? Would you treat this patient with steroids and MMF? Would you rebiopsy? Remember, there are only 2 glomeruli on light. Maybe we missed a glomerular segmental glomerular lesion. Would you give the patient rituximab, or would you just watch the patient for now? And watch can be, ACE, ARB, SGLT2, but not immunotherapy. These are the point of number 5.
Wait for some more votes to come in. There we go. Stop it there and share.
So yeah, so kind of in a good mixture. Steroids plus MMF. Steroids alone wins. Watch for now is I think just slightly under steroids plus MMF. Got a couple people want to rebiopsy, and rituximab is another possibility. So it's an interesting case. Casey, what would you do?
I'm between steroids alone and watch for now. I'm between those two, but because
You
in my
don't, you don't get
experience,
to be
these-
between those two.
the chronic interstitial nephritis don't really seem to be steroid responsive, but the fact that our creatinine keeps going up, I wonder if we may have missed areas where there have been more acute damage. So I'm probably favoring the steroids alone as a because of the AKI, because of the creatinine rise. But if I saw that biopsy with the areas that we saw of chronic interstitial nephritis, those tubules are not coming back. So that the biopsy tells me, just watch for now, or just watch, not for now, just watch, don't treat. But the creatinine rise tells me steroids. So I'm going to go with steroids.
Yeah, I mean, the argument is you're absolutely spot on. What was in my mind, it's really unimpressive, but there's something going on that's causing renal failure.
Yeah.
Plus, she's leukopenic, right? I mean, she's also leukopenic. She's got an anemia. Who knows if that might not be related to her lupus too?
Good point. Steve, what would you do?
No, I agree with Casey. I was kind of, there are all these potential options. I agree with steroids, and probably don't even need to use very high doses, to be honest. You could probably start her like 30 milligrams.
Well, that's an interesting point, because we've had this. I don't know if you remember what your number one mentor, Dr. Lewis, once said. Was it to Dr. Sinsicol about treating interstitial nephritis?
I know.
Well, we won't repeat it, but 30. Let's just put it this way: 30 milligrams was not his first choice.
I got it.
Pravir, what would you do?
I think exactly what Casey said. I would do steroids just because the creatinine is going up, even though the biopsy itself seems more chronic. It wasn't the best sample. She has enough other kind of features of lupus in terms of her CBC that I would do steroids alone and see what happens. And, going into the fact that it may not work, but at least giving her a shot. And I would start with, how much did she weigh? I can't remember how much she weighed, but
Not a lot.
no. I mean, real nephrologists would do 60, but maybe 40. Okay.
That's the line. Was it you or was it Marvin that?
Oh, you told me. That's I'll never forget.
So the line is, I think we had an case of interstitial nephritis, and I think Pravir said 30 milligrams a day. And Dr.
Yeah, but
Lewis said,
she's 75 years old, and older people.
forget about the age, Steve. Don't ruin this.
Older people metabolize steroids a lot.
Yeah.
No, probably for her. Yeah, no, it was just, it's.
Don't ruin the story, Steve. You said real nephrologists use 60 milligrams a day.
I got that. I took the hit.
Luckily, I was a first year fellow, so I had still time to become a real nephrologist.
Yeah, you survived. You're on the faculty, so that's a lot to survive an attack from Dr. Lewis. But it was funny at the time. Which we all know Dr. Lewis. He doesn't hold back.
Can I
It was
chime in
funny if
here?
you're not on the receiving.
Yes, Dick, please.
I said it-
I would have picked steroids and MMF because of the recent episode of a lung abscess. I want to avoid as much steroids as possible. And MMF might have a steroid sparing effect. And I think this is an antibody-induced disease. And steroids are good for inflammation, but they're not very immunosuppressive. So I think if we recognize that she's got an autoantibody-induced disease, that an immunosuppressive agent might be more appropriate than just pure steroids, which are very good for inflammatory aspects, but they're not very good for immunosuppression.
I think that's an excellent point, and I put it in there, kind of not even thinking that far. More is just if we're going to give some kind of induction therapy, how far do we go? But I think it's a valid point that this is not. It's really not an acute interstitial nephritis pathologically, as it is so much an immune complex disease. So I think that's a really good point.
Well,
And for that matter, you could make the argument for rituximab.
yes, you could, but I think that staining in the Bowman's capsule is very, very significant in terms of an autoantibody disease.
Yeah, that's a really good point. Anybody? I'm sorry.
Why isn't this Abba? You have an elderly patient.
So let me
think this is
give my little presentation. We'll come back to that.
Okay.
Go ahead. You can control the screen. Yep.
Is there a blank there, or is it delayed?
I put it in a blank. Keep on going. It should be. There you go.
So, to give you a short answer, Mario, I don't know. David can defend this later, but I was driving into work today, and Abba came to mind, and just for the grace of God, it came to, because I hate to be surprised in these conferences. So I've never seen a case of it. One of our ex-fellows had a case of it.
One of the authors in the paper you're showing, Rosales, wrote about it with Bob Colvin. Also the group at Arcana with Chris Larson. My point is, this is an elderly lady, had deposits in Bowman's capsule and the tubules, which, as you all pointed out, look like an autoantibody. And I did not see, maybe I missed it, electron dense deposits in the mesangium.
There were a couple small ones.
There were, yeah, okay.
Yeah, but you really had to look hard.
So,
Well,
I mean,
well-
the reason I'm bringing it up, for those in the audience that don't know, is a disease where an antibody is directed against megalin, very rare, but it progresses to end-stage kidney disease, so it must be treated with immunosuppression early on.
And
Anyway.
like I said, the only reason I know about this was because Dr. Chintav Shah had a case of it, one of our fellows, and we worked on it together, and that's where I learned about it. It's extremely unusual, extremely rare, like 50 cases or something. And it is, just you're right, it's an antibody against megalin, and for many reasons, it looks like this. So I panicked this morning, and I called David. I said, David, any possibility that this is, Abba disease? And we went and looked kind of at the literature. The question was brought up of where these deposits are. They're not, in Abba, they're more in the basement membrane, even though it's directed against the brush border. The deposits you see are in the basement membrane. So we went back and looked quite a bit at the case and found these mesangial deposits, found very mild as they are. We found some mesangial deposits. I don't believe that you typically see antibodies in Bowman's capsule in Abba, but I've got 4 case reports. But generally it looks like this, and I think Dr. Reen brought up the statement that Abba is associated with lupus nephritis. So, I mean, there's probably pure Abba, and there's probably, maybe like many things, there's autoimmune overlap, and maybe there's Abba associated with lupus. But the pure Abbas are really, it's very rare and very poor prognosis, and they don't seem to respond to therapy, from what I remember. And it still leaves me a little bit befuddled here because the degree of interstitial fibrosis is very out of proportion to inflammation, which kind of gets to Dr. Glassick's point. That, I suspect this has been going on a long time, that the primary disease here is antitubular antibodies and leading to chronic interstitial fibrosis, which we really need to turn off. So I don't know, Mario, I think it's a really good point. And I don't know if there's an answer other than getting, we'd have to have special stains done for megalin, and David's going to look into that, see if we can send. I don't think it's going to change what we do, but it is an interesting thought.
Would be interesting, just contact either Larson or Colvin at MGH, and those two have the antibody to.
I think it's a really, really good point, and I'm only glad, I'm so thankful I thought of it this morning, didn't get caught off guard, because in my mind this was all lupus, and this was just an odd presentation of lupus, and so I found this case report, and it's not, a lot of times people write stuff and not to give extra credibility to the authors, but these are no schmucks here, from the Ohio State and from Arcana. That's very important kind of renal pathologist there. And their cases, except for being an older woman, and I actually didn't know that the Abba was more common in older people, but this is a 36-year-old woman with lupus for 2 years, had synovitis, blah, blah, blah. She was on 20 prednisone and Plaquenil, and she's only on routine follow-up with rheumatology, was found to have an elevated creatinine where previously it was normal, was 1.5. And her urine protein her only had trace proteinuria, not much on sediment. And again, mild serology here. SED rate was 32 like ours, but the complements were normal. Double-stranded DNA was, mildly elevated like ours. But it was the creatinine increase that prompted the renal biopsy, and this is what they found, which doesn't look that much different than ours, except that the tubular deposits on the right are a little more prominent. It's more prominent on EM, but maybe not as prominent on IF, as they found. So if this is a lupus case, if this is a lupus alone and Abba, maybe we're just playing with, terminology or, whatever. I think this is similar to what we have. They gave prednisone 1 milligram per kilogram per day and MMF for 6 months, and then put the patient on MMF alone. Further workup in their case found that their patient was SSA positive, but had no symptoms of Sjogren's. And after we got this biopsy, I did an SSA, and ours is also SSA positive. But I spent a little time this morning looking at all the, renal lesions associated with Sjogren's, and it's not really typical. The deposits you see in Sjogren's are often when you see a cryoglobulin or something. And you don't typically see this kind of tubular basement membrane deposits. Although, again, it depends if you're a lumper or a splitter and everything else. But that's kind of where we were with that. And this was their case, showing that the creatinine went from 1.6 to 1.4 asymptomatically. Found routinely. They started induction therapy here with both, and 12 months later, the creatinine was down to 1, which stayed at 24 months. Again, now this patient's being maintained on MMF for maintenance. And here was the proteinuria, not as much as ours, but again, our creatinine was higher too. Either it's worse or being caught later, but went from 500 milligrams down to about 100 to 200. So I think this is a nice clinical response. And their patient being young, it's good because the prognosis is good. As it's not so good with Abba. So what does that leave me? I don't know. Does that mean that this is what we have? I don't really know. David and I talked a lot about it. David felt fairly strongly that there was enough extra glomerular deposits in the Bowman's capsule and the mesangium that he would just call this a lupus tubular problem. But again, I don't know if that's enough or not. And I think if we can, we'll try to get stained for Antimegalin, because I think that's a really interesting finding, and it is so rare. I don't know if it's going to change anything. I started the patient on prednisone, 60 milligrams a day, gave her PJP prophylaxis. She got Procrit for her anemia, and I just saw her today. She looks fantastic. She feels better, for whatever that's worth. That could be just being on prednisone. And this is her first follow-up to get some blood and urine, and so I'll kind of know from there. But my plan was, if she got any better, would be to put her on MMF. But honestly, I mean, maybe if she's not better, I'll still put her on MMF per Dr. Glassick's suggestion. I think that's a good point, because we don't really have much to offer her. And I think she's doomed. I think the writing's on the wall that she's doomed if we can't turn this off. And I haven't even ruled out rituximab either. It's a possibility. I just have to see and think about it a little bit. I like the idea of attacking the antibody, though, which is why I was thinking about rituximab more than MMF. So I think with time we'll find out. But it's not something I've seen, isolated tubular deposits like that without anything else going on. And literally, we had to look hard to find those mesangial to kind of keep it in the lupus spectrum. And I think David is kind of supporting his underlying lupus diagnosis. But you never know. So if I do find out, I'll certainly report back and let everybody know what's going on.
Yeah, and let us know her renal
Roger?
response and follow up too.
Yeah. Yes, Dick.
I think we ought to clarify the situation with Bowman's capsule deposits, because that is one of the characteristics of Abba. They have lots of immune deposits in Bowman's capsule.
Well, when I was looking at it, I was thinking, I went back and I looked at the reports and I didn't see that. But I trust you totally. I didn't look extensively. But what I was thinking about is, the Bowman's capsule kind of goes right into the proximal tubule. And I don't know, is there any megalin in Bowman's capsule? I suppose there is. I'm not sure what it's doing there, but, it just seems like the proximal tubule is just a little modified Bowman's capsule in a way. I mean, I know the cells are different and they're not, you don't have microvilli and everything, but I did think about that. And so I don't know, I honestly, I hope you guys are right, because then I'll have seen a case of Abba and I'll think about it. Dr. Reen has been all over it in the chat the whole time. Once he gave up on cast nephropathy, he's been all over it. So, as usual, our audience is brilliant. And I'm just, like I said, for the 14th time, I'm thankful I didn't get completely blindsided by that diagnosis coming in today. And David, I had a chance to talk about it. So at least he had a chance to think about it.
Well, the parietal cells of Bowman's capsule are embryologically related to proximal tubule cells.
And that's exactly what I didn't know, but what I was hoping that someone would say. So, again, Dr. Roger Sekaran made up the point that megalin is the autoantibody in heminephritis, which is, interesting as well. So, yeah. So, I'll try to get back to you. And I don't know, David, if we're going to be able to do this, but I would really like to send that off. We're getting Mario sent a nice reference in the chat related to this as well. So, David, do you think we can do that?
Yeah, we'll certainly look into it.
Yeah.
Wasn't Megalin also associated with membranous, Dick?
I think he had to sign off.
Did he get off?
But
'Cause I thought Megalin, GP330, FX1A, these were all antigens that they thought originally were involved with certain types of membranous that you could see.
wasn't that the maybe I'm mixing thing up, but Dr. Lewis's case of
I put it in the, I actually
Oh.
put it in the chat. That was FX1A that they found. The brush border lit up and the deposits had antibodies to FX1A as well. I posted.
and it's associated with B12 deficiency, and that patient also had pernicious anemia, if I'm not mistaken.
No, that's Ismerlin-Gresbach syndrome. That was somebody else.
That's somebody else. Okay. Never
Yeah,
mind.
that's a guy I still follow. That's the Ismerlin-Gresbach syndrome. You're right, but that's a cubulin problem.
Oh, well, cubulin megalin. What's the difference? Obviously, today it's a big difference. But thank you, Steve. That's really good. Yeah.
No, but the
So-
one I posted, it was FX1A, but this was all about, this had to do more with membranous, and this case was membranous, but the brush border lit up and they found that the antibody was to FX1A, which was in the brush border as well as in the deposits. But that's why I always said, GP330, Megalin, these were all proteins they were talking about years ago when they were trying to figure out what was going on as far as the cause of membranous. And some of those were only found in animal models. And I have to admit, I didn't realize, for some reason, I thought Megalin was an animal model too, but clearly not.
Mario, you want to make a bet on this with some odds here? We'll make a public wager on whether or not it's going to be Abba or not.
Abba all the way.
You're in all the way. Okay. Listen, I love betting, so whatever you say, we're going to go with it. Anyway, a lot of fun. So glad the audience was as smart as they were today, and I'll try to get back to you shortly on this. We have a lot of cases that we keep promising about giving follow-up, and we eventually, maybe we'll just have a whole follow-up session of some of these better cases, but we'll certainly let you know. Thanks, everybody. Great conference. Thanks for all the contributions, Mario, Dr. Glassick, Dr. Reen, et cetera. Great read, Casey. We will be off next week, but we'll be back shortly. So everybody, until then, stay safe.